My name is Joanna Franks and I'm a breast and oncoplastic surgeon, and I'm going to talk to you a little bit today about why patients might require a mastectomy. In general, patients will come to the breast clinic with a symptom and be investigated. Once they've had their full assessment, we'll make some decisions about what is the bespoke treatment plan for them. When we're thinking about a mastectomy, there are factors which can affect the approach that we have. But in general, we think about tumour factors and patient factors. Tumour factors might be things such as the patient has multifocal disease, so disease across more than one area of the breast. Multicentric disease might affect more than one quadrant. They may have disease that sat very close to the skin or the chest wall, and they may have disease that sits around the area of the nipple. All of these factors might make your consultant talk to you about a mastectomy. There are other reasons that people might want to have a mastectomy, and these are all patient-related. So it may be a preference for a patient to think about mastectomy rather than breast-conserving surgery because they want to, for example, try and avoid radiotherapy. They may also come from a family that has a significant history of breast cancer or have an identified predisposition. Once we have made a decision that we need to undertake a mastectomy, we'll start to talk to patients about the different types of mastectomy we have. In general terms, this is usually a mastectomy with or without reconstruction. For some women, a reconstruction in the immediate setting is not possible, and this may be because of the way that they have presented or because of the type of tumour that they have. It may be because there's disease affecting the skin, or it might be related to the footprint of change. In most circumstances, although not always, we will be able to discuss with them a delayed reconstruction. Many women, however, will be suitable for an immediate reconstruction and would prefer to undertake this at the time of their mastectomy. When we're thinking about an immediate reconstruction, we're thinking about whether we are able to preserve the skin envelope without altering it at all, or whether we need to think about reducing the skin envelope to improve the shape or position of the breast. We also need to think about whether it would be safe or advisable to keep the nipple for a patient. When we are having these discussions with each patient, it is on an individual basis, and we all know that breast cancer is very common. 1 in 7 women in the UK will have this diagnosis. Because breast cancer is 2 words but hundreds of different types of breast cancer, you will find that everybody has a different treatment plan. Some patients will have treatment beforehand with drug therapies, and some will have it after. Some patients will know that they will be needing radiotherapy after their mastectomy, and for some patients we won't have that answer until we have their definitive pathology back. All patients who are facing a mastectomy will have an opportunity to discuss this with their breast surgeon and have the support of the clinical nurse specialists. In many hospitals, you may also be able to talk to patients who've previously undergone a similar operation, and if not, this is something that can be arranged outside of the hospital setting, very often with things like Macmillan and Breast Cancer Now and breast cancer care. A mastectomy aims to remove as much breast tissue as we can find. There are no concerns regarding the skin and in most cases, and therefore we will keep some, if not all, of the skin envelope depending on our approach. It's difficult sometimes for people to understand exactly where the surgery is going to take place, but it is important that you realise that the breast tissue goes all the way up to the clavicle, down to the lowest part of the breast that you can see, and into the armpit, which we call the axillary tail. So whether your scar is very small because you're having preservation of your skin envelope and your nipple, or whether it's a larger skin excision at the time of your surgery, you will have all of the breast tissue that can be found underneath the skin in this footprint removed. It's a large area, and that can be why it can feel a little bit uncomfortable afterwards. You can also notice some sensation changes over a much larger area than you had anticipated because of this. Patients often think that if we do a mastectomy, we're going to be able to take away every single breast cell. Unfortunately, that's not correct. We know that somewhere between 5 and 10% of the breast tissue is left behind, as it really is extremely difficult to know exactly where the breast starts and stops. On the morning or afternoon of your surgery, you should be greeted by a member of the surgical team who will confirm what the operative plan is. You will have given written consent, and this will be confirmed on the day of your surgery. You will also be marked to confirm the side that's being operated on. It's not unusual for marks to be placed on the chest wall at the time before the surgery, and these are used to help us in theatre to make sure that we can give you the very best result possible. During your surgery, you will have some local anaesthetic given so that when you wake up, you're not too sore. And our intention is that your pain should be very well managed afterwards with simple medical treatments. You will be given medications to go home with. Depending on the approach of your surgeon, you may or may not have a drain placed, and for some people, they'll go home with this for a few days. As with all things in life, there is some differences in the approach to dressings, but this will be explained to you by your surgical team. We will ask you to be careful for the first couple of weeks after your surgery until you come back to be seen in clinic, and we will encourage you to do very specific arm exercises, even if you've had lymph nodes taken out from under the armpit. These are graduated, and there's an information sheet that's available for you. We're very keen, as you can imagine, for patients to go home at the earliest opportunity because we know that that's where they'll be most comfortable, supported by their family and friends and within their own environment. Patients understandably can be concerned about what they need to look out for. Before you leave hospital, your wound will be checked by the ward staff or your surgical team, and your clinical nurse specialist is likely to have spent some time with you either before or after your surgery running through things. However, it can be difficult and sometimes a little overwhelming to remember everything. The most important thing is to make sure that you have a good look at how things are before you leave the hospital so that you can notice any early changes. In general, we'd ask you to look out for increased bruising, redness, swelling, and a change in your pain. If any of these things happen, we would like you to contact your clinical nurse specialist or the surgical team to make sure that they are happy that you do not need to come back earlier than your scheduled appointment. All patients will be seen in the clinics afterwards to be given their results and to run through their follow-up plans.